So I invite Dr. Parikshit Prayag for the next topic. That is, what is new critical care in infectious diseases in 2023. Dr. Parikshit, he is American Board Certified in Internal Medicine and Rutgers University, American Board Certified in Infectious Diseases, India Research Cancer Center, American Society of Transplantation Federation, Transplant Infectious Diseases Stanford University. Current designation is Consultant, Transplant Infectious Diseases, Dina Mangeshkar Hospital, Pune. Is expertise in the area of transplant infections, fungal infections, care assistance. Other highlights: only trained transplant ID specialist in India. Is section editor, infectious disease, Indian Journal of Medical and Pediatric Oncology. Is a reviewer, Indian Journal of Critical Care Medicine. Is a member, Transplant ID Subcommittee, Clinical Infectious Diseases Society of India. Is a member, editorial board, Journal of Clinical Infectious Diseases Society of India. Dr. Prayag, please take up the result.
So good morning everyone, and thank you once again for inviting me to this lovely city. So I'm going to be talking about what's new in critical care infectious diseases. And I thought that rather than doing this like a top 10 papers in ICOID in the last year, let us look at some of the trends that are changing, some of the newer things that are coming through in the world of ICU infections. So we'll try and look at a few aspects of ICOID that have changed probably over the last couple of years. The first thing is, have we settled the cephalosporin avibactam plus or minus Astrolam versus polymyxin debate for enterobacteriaceae? So a couple of years back, although there was emerging literature on the poor pharmacodynamics of polymyxins, we really didn't have a lot of data when it came to the New Delhi metallo-beta-lactamase producers. All the studies which looked at cephalosporin avibactam plus or minus Astrolam were in the setting of either OXA 48 or KPC producers. So the question still remains that in settings like India, which are NDM predominant, what is a better way to go about? Is it polymyxin based therapy or is it cephalosporin avibactam based therapy? Again, in the last 3 or 4 years, a lot has come through regarding the pharmacodynamics of polymyxin. We'll go through. We published this retrospective analysis in NDM predominant bacterias, and then later on there was a meta-analysis on this, and both showed that if you select out properly, which means that if you are testing for synergy for cephalosporin avibactam and Astrolam for enterobacteriaceae, the outcomes were better as against polymyxin based therapy, even against polymyxin based combination therapy. But does that settle the debate? Till we were doing this, there is emergence of PBP3 mutated E. coli, which means that E. coli which will not be susceptible to the combination of cephalosporin avibactam and Astrolam. The reason is that the final site of action for Astrolam is your penicillin binding protein 3. So even if you have cleared the enzymes along the path, which means that even if your avibactam has taken care of your CTXM or OXA 48 and you are left only with NDM and Astrolam, the Astrolam still needs to go and bind to the penicillin binding proteins. And here is where in the last couple of years we have had the emergence of this mutated PDP3. And this is a peculiar phenomenon which seems to arise with NDM producers. So if you have NDM producers like we have in India, there is a chance that you might have mutated penicillin binding protein. So that is why our synergy tests are looking poorer and poorer. A couple of years ago for E. coli, we wouldn't have the failure of cephalosporin avibactam and Astrolam. In the last couple of years, in various parts of the country, there is almost a 10, 20, 30% in some of the hospitals from Mumbai which have reported failure of the synergy of cephalosporin avibactam and Astrolam. So what do we learn from this? Two things. One is that synergy testing is important, which means that we can no longer trust cephalosporin avibactam Astrolam blindly for our E. coli. For Klebsiella still we are fairly in that zone where most of the times or almost all the times you will have susceptibility of the combination of cephalosporin avibactam and Astrolam. But it's not just PBP3, there are newer and newer mechanisms of resistance emerging for this combination. And as we all know, unfortunately in India, this combination is now far too easily available. In the last couple of years, since this brand has almost become generic, there are almost 40 brands in the market, and there are a lot of centers in smaller towns that you will see which are also starting cephalosporin aspirin as the first line therapy in ICU or even otherwise, so which is a big problem. And there are many resistance mechanisms emerging. For the lack of time, I won't go through all of them, but this is a beautiful article written by Dr. Balaji from CMC Vellore, and I would urge all of you to read this. This is loss of exclusivity of cephalosporin manufactured in low and middle income countries, a test for antibiotic stewardship. I think that is our biggest challenge in the last couple of years, not the stewardship part that has been an internal challenge, but the loss of exclusivity of cephalosporin manufactured. And where do we actually position it? So now cephalosporin manufactured shouldn't turn into another meropenem wherein it is used at the drop of a hat. So I think those are concerning things. What's new in the management of infections caused by carbapenem resistant Acinetobacter baumannii? So again, in this till about 4 or 5 years ago, everyone felt that monotherapy was adequate for Acinetobacter. So if you look at the international polymyxin consensus guidelines which were published about 4 or 5 years ago, many of the authors on those guidelines actually voted in favor of monotherapy for carbapenem resistant Acinetobacter. That has been questioned in the last 4 or 5 years, and now in the 2023 IDSA guidance, they are recommending combination therapy even for your carbapenem resistant Acinetobacter baumannii. This was a little bit clearer when it came to Enterobacteriaceae. We all agreed that we should be using combination therapy. But what about carbapenem resistant Acinetobacter baumannii? Remember, they don't have the luxury of cephalosporin avibactam plus Astionam. So what about our crab infections? So they are recommending combination therapy, but the more important question is which combination therapy? Again, this came out late in 2022 and more so in 2023. It was really implemented in most of the ICUs across the world that combinations of polymyxin plus meropenem don't work for carbapenem resistant Acinetobacter. So while we all agree that combination therapy is important, it's not going to be, the answer is not going to be polymyxin plus meropenem. This was actually reconfirmed, I should say, by this study. There was an IDA study which was published a few years ago which showed the same thing. So now where are we? We all agree that it should be a combination therapy, but we also agree that the answer should not be polymyxin plus meropenem. So what are our options? Our options include other drugs. So if you look at the IDSA guidelines which were published in 2023, late 22 actually, they are advocating sulbactam based therapy, sulbactam plus something, either sulbactam plus minocycline or sulbactam plus polymyxin. Where are we heading? Sulbactam plus durbobactam might be a useful antimicrobial in the next few years. It has just gone through phase 3 studies. The important thing here is that it takes care of your Acinetobacter oxus. So we did not have a BLI which took care of our Acinetobacter oxus. Avibactam can take care of OXA 48, but what about OXA 23, 24, 51, 58? These are our Acinetobacter oxus. So we did not have a beta-lactamase inhibitor which could inhibit your Acinetobacter oxus. So that is a hopeful drug. It is looking decent in phase 3 trials, but there is a but to everything when it comes to gram-negative resistance in India. So what is the but here? And by but I mean BUT. So what is the but here? It means that if you look at our enzymatic patterns, it is mainly OXA 23 and NDM. So what about NDM? We still don't have a BLI which is going to take care of our NDM. So while for our OXA 23 producers, sulbactam, durbobactam would be a good drug, it is still going to need help when it comes to our NDM producers. And as seen in this study which we published a few months ago, a lot of our isolates are actually OXA 23 plus NDM producers. Dr. Balaji has shown the same thing from CMC Vellore. So what's on the horizon for MDR gram-negative bugs? Going beyond cephalosporin avibactam and Astionam. So very call, if you have access to it, if your patient is rich enough right now to have access to it, is a useful drug because it can withstand hydrolysis by many enzymes, and importantly, it can withstand hydrolysis by the class B carbapyranases. So New Delhi metallo-beta-lactamase or Vimorin, your class B carbapyranases do not hydrolyze cephalosporin. The other advantage is that it is not affected by efflux mechanisms because it has a different side chain. So these are two very, very important advantages. NDM and efflux mediated resistance it can withstand. But what is the problem? The problem is that again PVP3 will be a problem in India when it comes to E. coli because it will not be able to overcome PVP3 mediated resistance. There are already AMCs, pseudomonas AMCs, which have shown the ability to hydrolyze ceftriaxone. So again, it's a good drug. It probably will be a good drug for our pseudomonas. It probably will be a good drug for our Klebsiella. E. coli might be a problem, and for acinato, again, IDSA is advocating it right now as a part of combination therapy, not as monotherapy. Plasmomycin, I think there is some buzz that there are companies who are interested in getting plasmomycin in India. It's a good drug, but where do we position it? It's mainly for our carbapenem resistant enterobacteriaceae. So there are aminoglycoside modifying enzymes of E. coli which don't affect plasmomycin as much as they affect something like amikacin. So there it might be a useful combination. So it might be one of the useful drugs to take care of these kind of scenarios or EBP3 mutated E. coli where we don't have a lot of options right now apart from fosfomycin. Eravacycline is like a bigger, better version of minocycline and tigecycline. So a lot of centers have either increased Tig resistance or they have either increased mino resistance when it comes to carbapenem resistant acinetobacter. And I think there eravacycline will be a useful drug in our settings. And then there are some which are still in phase 3 clinical trials. So if you look at aztreonam avibactam, so right now we have to combine ceftriaxone avibactam plus aztreonam. When we have aztreonam avibactam, from a PK/PD point of view, it is going to be much better because you are getting to use one drug, aztreonam avibactam. Cefepime N-metazobactam is being specifically manufactured as a carbapenem sparing option for your ESBLs. The problem is that in trials, piperacillin tazobactam hasn't looked as good as meropenem. So we need carbapenem sparing options for our ESBL producers which are as good and which are not options for our carbapenem. Although ceftriaxone avibactam is a good drug in that space, we don't want to use it for our ESBL producers. We want to safeguard it for our carbapenem resistant organisms. Cefepime zidibactam I think also will be a very good drug for our scenario. It has shown good activity against the metallo-beta-lactamases, which is interesting because zidibactam is not a BLI that inhibits the New Delhi metallo-beta-lactamase. This effect comes from the fact that zidibactam is able to enhance the antimicrobial properties of cefepime, and hence the Indian is not able to bother cefepime as much as it would have normally. So cefepime zidibactam in that space is a good drug. So PVP3 will be taken care of because the main site for that drug is PVP2. So our mutated PVP3s will still be susceptible to cefepime zidibactam, and there is hope when it comes to the metallo-beta-lactamases as well. And sulbactam, durlobactam we talked about. Cefepime taniborbactam I think we are still some way away from getting it. Then breakpoints, PK/PD data, these sort of things continue to emerge, these sort of things continue to get revised. So there has been a lot of talk in the last year about aminoglycoside breakpoints and trying to steer away from using aminoglycoside monotherapy, especially in the ICU. So the breakpoints have changed drastically. What was 16 before for amikacin is now 4 when it comes to enterobacteriaceae. The reason is that again, a large part of this is the PK/PD. So we are not able to achieve 10 times the MICs when it comes to peak concentration. So if you look at the pharmacodynamic target for aminoglycosides, a peak to MIC ratio of more than 10 is a good target. So it becomes very difficult to achieve those ratios when you have MICs like 8 or 16. So this was challenged. Again, the lung penetration is a problem. Different sites of infections can be challenging. So all these led these changes to be made, and now we have revised breakpoints for amikacin. There have been revisions in the piperacillin tazobactam breakpoints as well. Interestingly, stenotrophomonas minocycline breakpoints have reduced drastically. So anything up to 4 was considered to be susceptible till 2022. In 2023, this was revised to 1, again largely based on PK/PD data. So again, if you have stenotrophomonas in your patient and you have an MIC of 2, be careful. One way of overcoming it might be to use something like 200 milligrams BD of minocycline. And again, IDSA continues to review their dosing recommendations based on these PK/PD findings. So right now they are saying that we need to use ceftriaxone avibactam aztreonam simultaneously, both infused over 3 hours. I think this has stood for the last couple of years at least. Sulbactam, now we are using higher and higher doses of sulbactam. There are also recommendations for renal modification for the higher doses, because if you check ampicillin sulbactam or if you check ceftriaxone sulbactam, their renal modification doesn't do justice to the kind of dosing that we use for our carbapenem resistant organisms. And minocycline IDSA is saying that you can even contemplate using up to 700 milligrams of minocycline, which I think is outrageous, but at least 200 milligrams every 12 hours is the dose which is being increasingly used for our carbapenem resistant organisms. Then talking about pharmacodynamic concepts emerging, you must have, I'm sure, looked at the Mercy trial, which looked at continuous versus intermittent infusions of meropenem. Now, for a long time we have believed that it's the prolonged or continuous infusions of beta-lactam drugs which are useful, because it's the time that they spend above the MIC. Remember, it's the time that these drugs spend above the MIC of the organism that is important. So if they spend more time above the minimum inhibitory concentration, it's going to be better. This was challenged in this trial. Now, I wouldn't say that this is practice changing yet. Most of us still use prolonged infusions of meropenem. And remember, this is continuous versus intermittent. So they looked at a 3 gram 24-hour infusion versus 1 gram 8-hourly. Now, there were some limitations to this. So they did use other antibiotics in some of the patients. Their patients were very sick to begin with. The mortality, I think, in this trial is more than 30%. So which is higher than what is reported in other trials which are addressing this concept. So I don't think we are there yet, but it's an interesting concept which is being challenged. Also remember that meropenem does have some sort of a post-antibiotic effect. So it's not right to extrapolate this to other beta-lactams. So we'll wait and see, if we need to stick to our intermittent short dosing infusions for meropenem. Is it time to rethink our teicoplanin dosing? So in 2023, there has been a lot of noise about how teicoplanin dosings that we routinely use in our ICU are actually inadequate. So most of us would use something like 6 milligrams per kg IV DD for the first 3 doses and then go over to OD. So this has been challenged. In fact, the Japanese society now recommends much higher doses for induction regimens. So the target trough levels are between 15 and 30 for most infections, and what they recommend to achieve this is 10 milligrams per kg twice daily for the first 3 days. Now, if you compare that with what we are doing, this is actually, there is a significant amount of difference. So what do we do? Well, in your sick patients, you can think of higher dosing. Remember, teicoplanin is also a very poor ICU drug because it is highly protein bound. A lot of your patients are hypoalbuminemia. Now, in the first place, teicoplanin, I'm sure, is overused in a lot of our patients empirically. But in the setting of directed therapy, what we can think of is higher doses of teicoplanin. Or what you can do is teicoplanin therapeutic drug monitoring. We've just started doing this. Now look at the first 4 patients in whom we've done therapeutic drug monitoring for teicoplanin. Again, the levels are not as high as I would want them to be. Ideally, for my very sick patients, I would want them to be between 20 and 40, at least between 15 and 30. So if we look at vancomycin as strictly a drug that needs therapeutic drug monitoring, there is no reason not to look at teicoplanin as a drug that strictly requires therapeutic drug monitoring. Again, TDM for teicoplanin is not that hard to establish. It has a very good safety margin, which means that above 40 or above 60 is when you would start entering into the zone of toxicity. Really above 40 for cytopenias and above 60 for nephrotoxicity. So you have quite a bit of margin when it comes to teicoplanin. So for your sick patients, think about whether these patients need higher doses. Now, is there more and more evidence to start TDMs for polymyxins? So again, that has been something which has been discussed in the last few years, primarily because of this, that the PD targets for a lot of our organisms are out of reach by, with the kind of doses that we use. So, for pulmonary Klebsiella, no matter what AUC MICs you use, it is very difficult to achieve stasis even with monotherapy or with monotherapy. For your Klebsiella non-pulmonary infections, again, 2-log kill is very, very difficult. So what does it show? That even higher AUC MICs of polymyxins are not going to be the magic bullet against Klebsiella, and that was one of the reasons why the term susceptible was abolished for polymyxins. So now we have only intermediate or resistant, and this is to dissuade people from using monotherapy, especially for enterobacterial. So look at this study when they use higher doses as well as obviously when they use lower doses. Look at the number of people who are achieving good AUCs. Now most of our organisms have MICs between 1 and 2, if you are lucky, that is. So which means that if you are achieving AUCs of more than 100, your AUC MIC is probably going to be somewhere between 50 and 100. So and the number of patients who are achieving these kind of AUCs are also very, very minimal. So again, is it time to look at polymyxin levels again? This is a small experience. We have started doing polymyxin levels, but again, the first 8 patients show that polymyxin levels can be very erratic. Some patients can have high levels, especially if they have higher creatinine, but those who have a normal GFR can have very, very low levels of polymyxin. So think of the AUCs that we are achieving in our patients, and then think of those patients in whom polymyxin is being used for pulmonary infections. Again, a very, very poor pharmacodynamic setting to use polymyxin in. Now, this may not be too relevant to your ICU practice, but where do we place dalbavancin in our clinical practice? So, dalbavancin is a drug that has a very, very prolonged half-life. It's a very good gram-positive drug. It has a half-life of almost a couple of weeks, so which means that you can dose it every couple of weeks. So, again, not probably a drug to be used at this point of time in the ICU settings, where it has the maximum retail skin and soft tissue infections and completing therapy for bone infections. Again, completing therapy for bone infections probably doesn't apply to the ICU. So right now, probably not too much when it comes to using it in the ICU settings. Remember, it's not approved for endocarditis or for bacteremia. It is currently approved only for skin and soft tissue infections. Do we have newer headaches in terms of resistance? Yes, why not? So our Clostridium difficile is starting to look increasingly refractory to vancomycin, which is scary. And these are studies published from the US. This was just published this month. A high proportion of C. diff exhibited reduced vancomycin susceptibility, and we have been having that problem. In fact, we have been increasingly using oral teicoplanin in our patients for C. diff infections. Some of them have been responding, some of them haven't, which has actually led us to doing FMTs for some of our patients in the setting of refractory C. diff. So it's almost done. So if patients fail, sure. So if patients fail at least 2 lines of therapy for C. diff, and the fact that we don't have fidaxomicin, this perhaps remains the only option. Now, I am not saying that FMT should be routinely done, but the point here is that there are strains emerging which have increased vancomycin MICs. And I'll just end with newer drugs for Candida auris, which we hopefully will see in the next 2 or 3 years. So 3 drugs look good: fosmanogepix, then ibrexafungerp, and rezafungin. So ibrexafungerp right now is approved only for vulvovaginal candidiasis, but in the years ahead, I'm sure these would be good drugs. They won't solve some of our problems. For example, all are again limited by their urinary penetration, CNS penetration, ibrexafungerp and rezafungin especially. So they may not solve all our problems of Candida auris and sanctuary sites, but they will be good options for those isolates which are resistant to our traditional echinocandins. So I think I'll stop here. Thank you for your patient listening and look forward to questions.
Thank you, sir. Please stay down. Now I request Dr. Sima Samarinder and Dr. Sanjeev, please come on to the podium. Now all 3 topics are open for discussion. Please, sir.
I'm going to thank you all for your absolutely wonderful presentation, which completely fly over my head, particularly Parikshit's talk on antibiotics, which is almost always excellent, but it really bothers me. The fact that the way in which, I mean, even between your first talk and your next talk, every month I hear a different talk from you, the patterns of resistance are progressively changing. And clearly, you need to be an expert like you to be able to even handle any antibiotics under these circumstances. What is our solution to this? I mean, are we going to continuously, you're a rarer species than a sensitive microorganism of any kind. So I can't find somebody like you to come and teach me every time I need to treat these patients. But what I find frustrating is this huge amount of resistance which on a daily basis requires a new change in your antibiotic policy, and that doesn't sustain it for very long. What is our solutions? Just.
Well, I don't know, sir. I think you've seen the journey far more than I have to sort of predict long-term solutions to this. Now, FAST therapy is being advocated as something, which will help us get out of this cycle of beta-lactamase and beta-lactamase inhibitors, because no matter how much we do, there is always a mutation which seems to bother us. For example, ceftazidime-avibactam has gone that journey. Now I'm sure ceftarixol or cefepime-zidibactam will all go down that journey. So are there non-antimicrobial solutions to it? Again, there are people who have started using FAST therapy. I think in India we are still quite a distance away from it. That may be one of the solutions. Again, I mean, we keep talking about the same things like stewardship practices, trying to safeguard higher drugs. I don't know the answer to your question. I think you would answer your question better than I would.
I can't. I'm almost, I lost all my hair. Okay. No, because it is a very frustrating problem. We started with things that we thought was the easy solution, which is to change your antibiotic every few years. But really what we are facing is an accelerating problem. And the solution I can think of is if you have a critically ill patient, get out of the ICU as fast as possible. And probably even, there are nice new studies of saying don't intubate patients with a GCS of less than 8 like we traditionally are asked to do. There are a lot of ways in which we can prevent it, and I think we need to focus on that. Prevention is going to be far better than treating anything.
Absolutely. And I think shorter courses as well, that has been a focus also recently. Shorter courses for some of the traditional infections that we have thought of. We have always thought of bacteremia as something which requires 14 days. Now there are studies emerging which look at shorter durations. So using antibiotics, for shorter durations, and again, maybe safeguarding some of the higher drugs, restricting them, I don't know if it works in our settings. That's a whole different topic. So those could be solutions. I mean, not really thinking hard about some of the indications that we use antibiotics for. It was interesting, we were in one of the ID conferences and someone asked what is the number one reason for antibiotic abuse in India, and different people said different things, the usual stuff, over-the-counter medicines, general practitioners, poultry, and all those things. I won't name him, but one of our IT colleagues, he got up and said that the number one reason for antibiotic abuse in the ICUs in India is leukocytosis, which I feel is a very interesting answer. So we need to look at some of the things that we do, like giving antibiotics for leukocytosis, or the durations that we are using. Do we need ecoplanine almost upfront in all, not all, but in many of the patients who are started on this standard meropenem plus ecoplanine combination? Do all of them really, what are our own MRSA rates? I think these things could be simple things to start with, but I think the long-term solution and picture is scary.
Yeah. Thank you again. I mean, you are very patient to teach us about all these new advances, but about 50% of it literally flies over our head. Thank you.
Yeah, Dr. Prayag. I'm Dr. Venugopal, a PhD observer for this conference. So just I want to know about this. As Dr. Earlier speaker, earlier delegate has a question about the changing pattern of the antibiotics. So we know that yes, the CDC is there. So as per the CDC guidance, our antibiotic policies, is there any such board is there in India, like CDC, or we still are following CDC guidelines?
So sir, if you look at the resistance, so CDC, one part that CDC does well is, try and bring this data in the public domain. So for that, we do have ICMR and NCDC, so they do publish yearly reports. So if you look at, and they are pretty comprehensive, and I would say those are good reports. So if you look at, let's say if you want to find out that what is Acinetobacter doing in India, you can refer to the 2023 report. They will have, I think they have 30 or 35 nodal centers across the country, and they do collect the data on resistance patterns from all these centers. So there are thousands of isolates that they collect data on and publish, what is our own MRSA rate, what is, our Acinetobacter carbapenem resistance rate, what is our Enterobacter resistance rate. So one of the things that CDC does, I think we are doing it quite well. Now the accuracy of that data, of course, you and me cannot vouch for, but at least that data is out there. Now coming to antimicrobial policies, I think the bigger problem is implementing those policies in our settings, because I'm sure every hospital, especially around the days of the NABH audit, does have antimicrobial policies ready. But the problem is that how do we actually implement those antimicrobial policies? I think that is a bigger challenge for me. Maybe sir can some of you senior industries can comment.
The maximum amount of antibiotic problems that we have is actually OPD practice. 99% of the healthcare antibiotics that we use is OPD practice, and government regulation is the only way I feel to go ahead in this way, because that's the only way to curb antibiotics, at least in the periphery, I feel. Because intensively, I don't think we have much choice.
I think the problem is multifactorial, because if we say that in the ICU, I have had a patient who has already received antibiotics in the periphery. I think it's a practically speaking, it's a very valid situation that if your patient has come to you on polymyxin, meropenem and teicoplanin, and then he's septic, the only way you can go is escalate. You don't even have anything to escalate, and then you cannot de-escalate. So I agree that while we get stuck up in these situations, but I think not all patients are patients who have received antibiotics in the periphery. I think every think that fever is a part of the problem. Now there are doctors who say that my patients demand antibiotics for fever and cold. As an IT physician, I have never had a patient in my 6 years of practice in India who has said that I want antibiotics. Your experiences could be otherwise, but I think if we do counsel patients, I don't think they will be taking antibiotics at the drop of a hat. Pharmacies dispensing antibiotics definitely is a problem. We actually had this Sapkar program, which is very active in Kerala, which is the government program for containment of resistance, and it was a Maharashtra government initiative. There was a meeting in Mumbai, and they had invited fisheries and people from animal husbandry and poultry. Now, I was surprised because it really opened my eyes. It's not as bad as we think, in fisheries and poultry. I think allopathic doctors as well as homeopathic and Ayurvedic doctors, I would say, are abusing antibiotics, if not more, at least as much as those people, because we always tend to blame someone else for it. We blame the general practitioner, or we blame the animal husbandry people, or we blame the fisheries. I think all of us need to really look within ourselves also for antimicrobial practices.
The national antibiotic policy was declared 3 years ago, but I think the regulation has to come from within us. That the moment we stop treating fever as a manifestation of ceftriaxone deficiency, and we stop treating septic shock as a manifestation of meropenem deficiency, I think the regulation will come into us. And I agree with him. We are blamed. Where have we gone to regulate? We have stopped dispensing cholesterol to the poultry industry. Right? I have a dairy. I know how much antibiotics we use. We don't use. We use ivermectin. We use antihelminthics. We use those kind of. We don't use colistin and meropenem and ceftazidime avibactam for a fever. If my dog or one of my dairy cows has a fever, I don't use ceftazidime avibactam plus aztreonam and then debate whether monotherapy works. We don't do it, and it works in those animals. So actually the problem is somewhere here, and we are acting here.
Actually, sir, why can't SCCM and IMA come out with some awareness programs in the community?
We are doing awareness programs, contact programs. But the moment a regulation comes, even before it is published, a loophole is published. So that is the problem with the system.
There are no questions.
Sir, 3 lectures are excellent, sir. One question to Dr. Samuel, sir. Sir, you have mentioned about the applying cardiovascular physiology, the CVP and SCVO. Actually, they are very important markers. According to the cardiovascular physiology, basic physiology. But coming to the clinical application, they are almost stopped. CVP guided therapy or SCVO guided management. What is the main difference of this, the throwing out of the CVP and the SCVO?
So, first of all, I don't agree that the CVP has been thrown out. First point is I don't agree that it has been thrown out. It is like antibiotics. We have misused it, so it becomes resistant. But the way CVP is going, now the whole paradigm of ventilation, mechanical ventilation, initially it was lung protective ventilatory strategy, then it was diaphragm protective ventilatory strategy, now it has come to right ventricular protective ventilatory strategy. So when you use a right ventricular protective strategy, your incremental peak, if it makes changes to your CVP, that means your right heart is actually suffering from your ventilatory strategy. So it is going to come back, because CVP may not be a marker of volume status of the individual for you to act upon, but it is definitely a manifestation of your right ventricular compliance in terms of the intrathoracic pressures and the interaction, the heart-lung interaction. So that is one area where it will come back. SCVO2, why it has fallen out of favor is that it is not one entity or one intervention which can actually modify your SCVO. Long ago, way back in the late 90s, William Shoemaker tried to do hypernormal or supranormal oxygen delivery. And the solution to a low SCVO2 is not to increase the oxygen. It is actually to improve the cause of that low SCVO2. So, since we don't have an accurate understanding of how you can optimize it, we are not using it. But again, when you are resuscitating patient, it is still used in neurocritical care. An adaptation of SCVO to the jugular venous oximetry is used in neurocritical care still to see whether your cerebral perfusion strategies are working or not. So it's not a bad concept. Only thing is we are unable to understand how to apply it in clinical practice.
May I ask one question for you? Synergetic combination therapy of Restrenum and Septagimide vector will not work for E. coli. So then what is the combination therapy for E. coli in that scenario?
So may not work in the sense, we have now seen isolates which are resistant. For the most part, they still remain susceptible, about 80-90% of them. But in that case, again, one useful drug in that setting is fosfomycin. So most of the isolates of fosfomycin that we have, fosfomycin remains a very good drug for E. coli. The same thing cannot be said about Klebsiella because it may harbor the FOS enzyme and several other reasons which I won't get into. So it may not be the best drug for Klebsiella as monotherapy, but for E. coli, there is more and more data now about monotherapy for fosfomycin. In any case, in your sick patient, there is no reason why you shouldn't use combination of polymyxin plus fosfomycin. That would be a good regimen. Even monotherapy, we have had many patients in whom even bacteremia has been taken care of with fosfomycin monotherapy. So I think that's one of the good drugs that we have right now. There would be others like plasmamycin or cefepime, gilibactam, but again, right now, practically speaking, I think our best bet against cefepime, avibactam, Astronam resistant E. coli is fosfomycin.
Thank you, sir. Sir, Srinivas sir, you said that we should start maybe vasoconstrictors early on in sepsis resuscitation. It always bugs me that will change everything else, the dynamic parameters that we use. So, how do you go about it, sir?
So, whenever you have time, Varlakshmi, go back to what's trending on social media today. The 13 mils per kilogram body weight of fluid therapy has been called a hoax by the Surviving Sepsis Campaign guideline. That is a video that is currently trending today, this morning. So, I think we were doing things a little wrong in the sense that it is not advisable to start vasopressors before you have understood the volume status of the individual. But the problem is, that is okay if somebody has a mean arterial pressure of between 55 and 70, it's okay to play around with fluid and give time. But somebody presents to your emergency room with a map of less than 55. Right? The acidosis that kind of mean arterial pressure begets on the patient, by the time your fluid resuscitation actually reaches the target, the detrimental effects of acidosis on the vasomotor reactivity of the blood vessels as well as on the contractility of the heart would make it impossible for you to turn that patient around. So it is that category of patients whose mean arterial pressure is less than 55 and who are still requiring fluid resuscitation and you are taking time to resuscitate, you need to start early vasopressors, not to, again as I said, if you are actually giving an autofluid challenge by early vasopressor therapy. You don't need the 1 mics per minute of norepinephrine. Even 0.2 is enough to constrict the venous capacitance vessels and supplement the fluid challenge which you are giving to the patient.
Thank you, sir.
Physiology, but coming to practice in septic shock patients, we give fluid resuscitation and vasopressors, escalate to dual vasopressors and start steroids, everything, but still you're not happy with the mean arterial pressure. And when you see, you may think like your LV function looks okay. Then, but you keep on increasing vasopressors and you keep seeing peripheries going, mottling and all these kind of things. But how far can we go, keep on increasing for the numbers' sake? What do we do at this level? Do we look at the right heart function and try to improve the function?
One of the emerging areas where echocardiography is going to guide your therapy in sepsis and septic shock is assessment of the diastolic function of the heart, and that is an unrecognized or underreported entity. If you look at the diastolic assessment, there is a lot of diastolic non-compliance and dysfunction that happens early among patients with sepsis. So how to optimize that will be your target of resuscitation. Second, while you are resuscitating patients, correct, you are only focusing on the mean arterial pressure, your lactate. What is your acid base doing? How am I going to correct that? Not by giving bicarb. I mean, Chakravarti is here, he might disagree with me, but You know, the bicar ICU trial has been a big nuisance for us as intensivists because we have been arguing that don't correct numbers by giving bicarbonate to the patient, treat the cause. And now all the non-intensivists have this bicar ICU printout in their hands and they are showing on your face saying your own people have said bicarbonate, but that's a whole different context. That is for patients with AKI on whom you are going to prevent them from migrating or going on to dialysis. But while you are correcting your hemodynamics, you also need to address that acidosis component because that is the one which is making your vasopressors ineffective. It is, and those of you who have come to Kolkata for this year's Criticare would have seen our team present about the renin activity in sepsis and septic shock, and we are very humbled that it was selected for Kavita Kamneni Award. I mean, we are very grateful to the departed soul for having initiated that award, but we presented our data on renin activity in septic shock, and renin activity is a more earlier predictor of which patient is going to develop a vasopressor refractory shock. So it is we haven't yet understood the whole pathophysiology of refractory shock. We have understood a little bit about shock, but not about refractory shock. So when it comes to your first vasopressor, I don't think there is a debate. Norepinephrine still remains the first vasopressor of choice. But when you want to put the second one on, that's where an algorithm should branch off, whether I'm looking at a renin depleted state or a renin excess state. That is where the day we get angiotensin 2 into the market makes a difference. But once it comes into the market, it will go the same way as meropenem, colistin and aztreonam have gone. We will use it in the emergency room, and that it will kill patients. And then somebody will do a randomized control trial. Early use of angiotensin 2 versus norepinephrine, and they will say angiotensin kills more patients and will stop using it. The thing is, what are we using? To whom are we using? With what is the rationale? If you understand that, you will use the right drug for the right patient at the right time. That will prevent the vasoplegia from becoming refractory.
Thank you, sir. And one question, sir. Regarding this feeding, hypocaloric feeding. So actually, how do you schedule the feeding in a burns patient who is around 50 to 60%, who is having deep burns? Because they go into different phases.
So calories per se cannot be predicted. That's very clear. You know, calories it's impossible to predict, especially if you have burns. Remember this, but I can be certain about the fact about calories only if I measure it. And the way to measure is by direct calorie entry. This is a gold standard. I mean, there's nothing better than IC that's there. Short of IC could probably do volumetric capnography, and with VCO2 you can actually figure out the calorie requirements. But if you don't have both, then the only way we can do that is to actually feed lesser than usual. What we've understood is in acute illness, we should not prevent the autophagy from switching off. Autophagy is a very important mechanism that happens in the critically ill, acutely critically ill patient. And it is this autophagy that is a real housekeeping mechanism of the body. The moment we actually switch off autophagy, then we start doing all type of badness. And the only way we can switch off autophagy is by actually reaching calorie requirements. So never do that. I think 1/3 the calorie requirements given by predictive body weight is probably the way to go in acute critically ill patients. Remember this, even after the CRP goes low, that means inflammation is going low, still the albumin remains alarmingly low for a long period of time. So start low, keep it low, let the illness get better. The magic of nutrition will occur only later on. Don't be aggressive on it.